when people lose weight, they need less structural support. It is only the structural muscles that undergo hypertrophy, but that is normal because people have lost weight. So that is a school of thought who feel that this is a neutral observation. There is another school of thought which thinks that because fat in obesity and diabetes infiltrates muscle, weight loss removes fat from the muscle, and as a result, even though the volume of the muscle is less, it is healthier muscle.
Mm.
What we don't know is whether this observation from the DEXA scan translates to bad outcomes. We
Yeah.
don't know if it translates to a reduction in physical function or falls and fractures. Okay. Until we know, the best thing we can do is to err on the side of caution, which means that let's assume this is a bad thing until we hear more about this and try to preserve as much muscle as we can. And as far as I can think, I don't know if you have got any other suggestions. I can only think of two ways of doing that, which is by maximizing protein intake, but also by maximizing physical activity and more specifically anaerobic physical activity. I don't know what you do to counteract this muscle mass loss.
That is absolutely the same, two things that I would do and encourage. And again, when we're talking about obesity management, it is a complex thing. So we talked about the mental health issues, the diet. So it's so important that they are seeing a clinical nutritionist that is supporting them with the sort of protein intake that is adequate, and then the physical activity component there. So muscle strengthening exercises have to be incorporated as well in order to try and reduce this a loss of muscle, as we see with our patients that have undergone bariatric surgery. So again, re-emphasizing on the fact that it is always a holistic sort of comprehensive multidisciplinary approach for management that actually leads to better outcomes and for better clinical outcomes for the patients. So we've discussed quite a number of topics. We've looked at reassuringly that there isn't any risk for cancers. We've looked at suicidal ideation. We've talked about the eyes and the more common sort of GI side effects. Are there any other things that you would think about and how you counsel your patients on misinformation that may be out there from social media and from what they hear from friends, and sort of the potential side effects of obesity medications that may actually impair their adherence to the treatment?
I would be careful. Well, when it comes to the myths that are circulating, there isn't, I suppose, much that we can do apart from trying to inform people through direct communication and also through our own presence in media uh, to try and explain and reassure appropriately. And that is also the nice thing about having a team looking after you, that instead of going to the media to get the information, you go to the team, right? Because if you're doing this on your own, you don't know where to turn to, and you might be misled into stopping the medication. So a few more situations where I would be careful. Women taking these medications can suddenly become very fertile. So I would suggest being cautious with that if they are not using contraception, and also ask them to stop certainly the weekly medications for a minimum of 4 weeks or so before planning to conceive. Certainly not use them during pregnancy, and breastfeeding. It would be advisable that these medications are avoided, even though the risks are completely theoretical. Hypoglycemia, it's extremely rare in people without well, even with or without diabetes, extremely rare. And it is more common in people who have diabetes, as you know, who are taking sulfonylureas or insulin, and therefore the necessary adjustments need to be made so that people don't have those side effects. And I think that's something that we've been doing in diabetes for many, many years. It should not come as a surprise.
Mhm.
If we stay on the diabetes field, you did mention earlier about your practice with diabetic retinopathy. So we know that there is only a very small signal of worsening of retinopathy, and this is usually when we reduce glucose too fast, because these medications have now become very potent. So this is a paradoxical deterioration in this microvascular complication of diabetes. Therefore, what we can do is we can slow down the reduction in the glucose by titrating these medications more slowly. That's one option. The other option is to wait for people who have active retinopathy to be treated, and then when they're more stable to start the treatment. I think both are equally fine options. And obviously, as you said, with good communication with our ophthalmology colleagues. With regards to the elderly,
Mhm.
the our experience with this cohort is in the clinical trials is small, but again, we haven't seen any signals of any differences in the response or side effects. But because the exposure of those of this cohort to the medication is less in the clinical trials, we just need to be careful, yeah, and to be a little bit more cautious again with titration, side effects, etc., because this group of patients may be a bit more vulnerable to the complications of the condition. But again, I really want to stress here one more point before we move into the panel question is that recently a report from the MHRA, the medicines regulator in the UK, demonstrated that there were fatalities. In fact, I think I have the slides for that. There were fatalities in people who were using those medications, and this again doesn't help me at all. In fact, it just scares people. Here are the actual numbers, right? 18 fatalities with tirzepatide, 29 with semaglutide, and 35 with liraglutide. But what I always say is that people who take these medications in the same way that people that take statins or ACE inhibitors, they are allowed to die. Okay. Now, this doesn't mean that the ACE inhibitor killed them. It doesn't mean that the statin killed them, but something else can kill them, but they will just happen to also be taking the medication. So this is the difference that you have just described between correlation and causation. So we need to know if these fatalities were caused by the medication, which I think is highly unlikely based on our experience of the randomized controlled clinical trials. But if there is a link, we need to investigate that link. We need to investigate why there was a fatality and what the combination, what the link with the medication was. From a practical side, this report from the MHRA, the only thing that it has made me do is to tell patients when I see them for the first time that if their side effects are getting severe, they should not sit on them. So I don't want people with pancreatitis and cholecystitis staying at home and taking paracetamol. That is problematic. So I have a lower threshold for asking people to be checked out in the hospital if they have severe side effects. So that is the only thing that this report has made me change in my practice.
Right, so that was quite comprehensive. We've covered quite a number of topics that have featured in the tabloids, and you've elegantly demonstrated through the scientific evidence, on the actual risks that are associated with some of these complications. What we probably would like to do now is switch on to the Q&A and allow our audience to ask their questions as well. And I can see there's already quite a few of them that have come in. There is one regarding hair loss, and I was sure this was going to pop up because I've had that question a number of times in clinic as well, particularly from women. And so what has been your experience with use of GLP-1 based drugs and hair loss?
I'm going to take you back to, again, our experience with bariatric surgery, where we've known for years that during the first year of weight loss, where the weight loss phase is much more rapid, people lose weight, and in association with that, they lose hair, and they also find that their nails can become brittle. And this is just a normal physiological reaction of the body in a catabolic state. Mm-hmm. So what happens again with this pattern is that when people reach their plateau after bariatric surgery, the hair loss stops. Now, unfortunately, I don't think the hair regrows, but at least it stops. So exactly the same happens with these medications. It's not that the medications themselves, the GLP-1 molecule, has an effect on hair growth. It's the weight loss that causes the hair loss. And when people reach their plateau, the hair loss will also stop. Now, you're going to ask me what people can do to mitigate that. And I must say to you that over the years, I have not found many things that work. Probably the safest thing you can try are just like supplements, micronutrient supplements for hair and nails, something like that. Nothing too complex or expensive. You can see if that works and if it makes a difference. But beyond that, I don't know if you have used anything else and that has had a meaningful impact.
Not really. Just making sure that they're on good diet is really important, and making sure that you address the micronutrients as well. There is a question from the audience with regards to our approach for a patient that has a suspicious thyroid nodule on an ultrasound scan. I know we talked about that earlier on. But the question here is if the person refuses to be investigated further, would you still offer the patient, a GLP-1 or GIP agonist if you thought they had a suspicious nodule, but the patient said, I don't want to be investigated further?
Yeah, I think it would be foolish if someone has a suspicious nodule not to be investigated. So I think in this specific situation that is being described there, even I would not stop those medications because, and I don't think it's a big deal. Just get it investigated, make sure it's okay, or have treatment if necessary. And if it is not medullary thyroid cancer related, just go ahead with the treatment. Right?
With the treatment, yeah. So I think safety always comes first, and do no harm. So I think that would be a very pragmatic approach. There is a question around conception and the use of these medications, and the question here is saying, what is the sort of time frame we would want to stop the weight loss medication before somebody plans to conceive? Is there any recommendation that you have?
Yeah. So again, I need to remind everyone that these risks are theoretical. There has been some evidence of teratogenicity in animal models that were treated with these medications, but we don't have any reports of teratogenicity or issues with the pregnancy in humans. Okay. And it's unlikely that anyone is going to do a trial into this in the near future. Therefore, we just need to be cautious and use the basic principle of five half lives.
Okay.
So I would stop the weekly medications at least 4 to 5 weeks before conception. I would stop the daily medications for 5 to 7 days before conception, which means that you continue the treatment and the benefits of the treatment as close as possible to conception, but you do not expose the woman to the effects of to the theoretical effects of the medication itself during conception.
Hmm.
So uh, that would be my approach.
Yeah, I think so. That would probably work best. There is another question also again around conception. And here they're asking about what is the association between the use of these medications and women who are taking oral contraceptives. Does it affect the potency of the oral contraceptive? Would they require to have higher doses, for instance?
Yeah, there are a couple of studies that have shown a reduction in the plasma levels of these medications
Yeah.
by about 20% or so after a single dose of administration of the GLP-1 based treatment. So, and this was in women taking the combined oral contraceptive pill. Now, is that of any clinical significance? Probably not. We
Okay.
don't know. So, what is the recommendation at the moment is that during the titration of the of the weekly medications uh, in women that are taking the pill, it would be reasonable to ask them to be a bit more cautious, potentially use other forms of contraception as well, because of this theoretical concern. But when women are stable on the treatment after the titration, then there are no risks associated. There are no links between low absorption of the pill and the use of
Okay.
these medications in the long run.
Okay, that's quite reassuring. So there are a few more questions that we could probably take. And there is a question that just come in, and they're asking whether we need to rule out cholecystitis before starting somebody on an injectable incretin therapy.
I suspect the question is more about ruling out gallstones rather
Yeah.
than cholecystitis itself. And the answer is that I don't do that because again, it is not going to help me. It is not going to change my treatment. It is only going to scare me and the patient probably without a good reason.
Mhm.
So if the most common scenario that I experience is that I have had patients who have had symptomatic cholecystitis
Yeah.
Recently or symptomatic gallstones in the last few months, and they need an operation, right? And the question is, do I start the medication or do I wait? Okay. So I must say to you that in those people, I wouldn't start the medication because any form of weight loss, as you know, can exacerbate gallstone disease, right?
Mhm.
So if they have got existing disease, then by giving them medication, I'm just playing with fire.
Yeah.
So I would normally ask them to have their operation, and when they have recovered nicely after that, I would start the treatment. So, but I wouldn't routinely scan people's gallbladder before treatment. Definitely not.
Yeah.
Now, there will be some people where the surgeon, the upper GI surgeon, has asked me to cause weight loss to make the operation safer.
Mhm.
Now that is tricky,
Yeah.
okay? Because then you're a bit stuck. Do I? So that I would leave to people's judgments. as
Mhm.
to what they do in that specific situation.
Okay. So there is another question that is around contraindications of these agents. Are there any specific patient populations or risk factors that would contraindicate the use of GLP-1 receptor
Okay, so that's a good question, and I have thought of this in exactly that way because I'll give you the list of people that I would not start the medication. It's a very small list, but I will give it to you based, and it is based on what we have just discussed and based on my own clinical experience. So I would not give these medications to anyone who has got a personal or family history of medullary thyroid cancer or MEN, multiple endocrine neoplasia. We discussed that. I wouldn't. I would probably not give this medication in people that have got active gallbladder disease. We have just discussed that. I wouldn't give this medication in people who have previously had pancreatitis, but I don't know the cause of the pancreatitis. So if this is idiopathic pancreatitis, I wouldn't use the medication because I think I would be playing with fire again. Now, remember, generally speaking, pancreatitis is not a contraindication. Previous pancreatitis is not a contraindication. It's usually a caution. So again, I would use judgment and say that if someone has had, I think you will agree, the most common cause would be gallstone pregnancy,
Yeah.
and they have had their gallbladder removed, then I know that the source of the problem has been dealt with, and therefore I would be comfortable with caution to start these medications. But I wouldn't do it in someone that hasn't got unidentified cause. On that point, that reminds me another scenario of hypertriglyceridemia. Not
Mhm.
that common, but I think you may have also experienced that in which someone is triglycerides are high, they're being treated with a fibrate. Do you give the drug or not?
Mhm.
Because of the concern about pancreatitis. Again, I would say use judgment there.
Mhm.
We know that these medications, GLP-1 based medications, reduce triglycerides.
Yeah.
So that's why it wouldn't stop me from using them. Again, I want to hear your thoughts about that. But I would counsel the patient and I would say, listen, your risk of pancreatitis because of the combination of the triglycerides and the GLP-1 is theoretically higher
Mhm.
compared to someone else. Shall we go ahead? So then it becomes a discussion of benefits versus risk. But that is very much a shared decision making between me and the patient. What do you do in that specific scenario?
Yeah, so again, it is a risk-benefit ratio. It's very individualized. As you say, severe hypertriglyceridemia is not a very common clinical presentation. And therefore, as long as the patient understands the risk of what might happen, and we take a shared decision together, we go ahead. And of course, if at any point we feel that they are developing pancreatitis, caution them about if you have any abdominal pain or you're feeling that you're a little bit unwell, please immediately come to the emergency and don't wait there and say, okay, I can take the paracetamol and wait on that. So yeah, it's a very sort of individual decision that I would take from patient to patient. On the same line, there's somebody who's asking whether checking amylase and lipase prior to starting the injections can help. And, what are your thoughts on that?
This is not something that I practice. In fact, what we have recently learned is that any rises in amylase or lipase during treatment with GLP-1 based medication probably means that the medication is working, or that just it means that the patient is taking it. The problem with measuring it and being high is that it again scares you, scares the patient, causes a lot of unnecessary investigations. And the rise in these enzymes does not predict the occurrence of pancreatitis.
That's right. Yeah.
So again, this is a little bit of a remnant from clinical trials, commercial clinical trials, where unfortunately we are, because of regulatory reasons, forced to measure lipase, and then sometimes we find it's raised, and then that causes a lot of chaos. But again, I have never picked up a pancreatitis based on a prophylactic measurement of lipase or amylase.
And reassuring, I remember from the LEADER trial with liraglutide that although there was a sort of highish lipase
Correct.
amylase levels, it didn't translate to an increased risk of pancreatitis in that patient population. So that's, in the recommendations, we don't recommend, just as we said, you don't need to do any ultrasound, thyroid scans or calcitonin. Again, you don't need to check those before starting the patient on the treatment. What's your take on the use of GLP-1 receptor agonists in patients with type 1 diabetes?
Oh, that is a fantastic question. And we have been peripherally involved in some clinical trials that are being run on that. And I think that people with type 1 diabetes and obesity get a bad deal because they are not usually studied in the clinical trials. And when the medications become available, people are very reluctant to use them because they don't have type 2 diabetes. So I think they're left undertreated.
Yes.
And I think you will agree, and probably with your more experience in the Gulf as well, that the rates of type 1 diabetes and obesity are really good.
Yeah.
Again, it wouldn't be a contraindication for me. The only thing you need to be careful about, as you know, is because you know that you're only going to be operating by improving insulin sensitivity, not insulin secretion. And the DKAs will only happen if someone is super enthusiastic, over enthusiastic with the reduction in insulin doses. So I would be therefore slow with the reduction in insulin doses. And these days, because a lot of patients, obviously, certainly with type 1, are using continuous glucose monitoring, that makes, I think, our lives easier in the reduction of the insulin doses and then the avoidance of diabetic ketoacidosis. So certainly will not be a contraindication.
Yeah. Okay, that has been my experience as well. The only other thing that I tend to caution them about is the increased risk for hypoglycemia. And, when they start with a GLP-1 and they're having some sort of GI side effects as well, and they're not taking enough, then they have the risk for hypoglycemia. And we kind of try to explain that to them as well. I think in the interest of time, we might just have time for this one last question that somebody from the audience has thrown in. And this is with regards to gastroparesis. And so those patients that come in complaining of nausea and vomiting of different severity, what would be the sort of stepwise approach to rule out gastroparesis?
There is only one report that I know of, and I have the slides for that earlier on, but which demonstrated a higher risk of gastroparesis, however you define that, and I will explain how they defined it, or through the use of GLP-1 treatments versus other medications to treat obesity. In fact, the way they defined it in that report was the use of a prokinetic agent. Now, the use of a prokinetic agent to me doesn't necessarily mean gastroparesis. It means that someone may be using a gastric emptying medication because of side effects of the GLP-1 based treatment. So I really don't think we have got a clear link between the two. Even if there was a link, right? The gastroparesis, because of the medication, would be fully reversible. I cannot think of a physiological reason as why it should be permanent, right?
Yeah.
So it also depends on how do you define gastroparesis. So are you going to do a gastric emptying study? Well, you're likely to find that the gastric emptying is slow. So does that mean someone who's got a diagnosis of gastroparesis? I don't think so. The people that I would be more careful about
Mhm.
are the people that we treat with type 1 or type 2 diabetes that have got an existing diagnosis of
Mhm.
gastroparesis. Now, there, I would be very careful and I would think twice about the use of these medications. But I don't think this entity of gastroparesis, the more I think about this, I don't think that it is uh, a development which is chronic, a potential chronic development after the use of this treatment. So I think it's just, again, in the first few weeks or months of treatment, it might be part of the side effect profile.
Right.
And
Right.
I will finish off by saying,
Mhm.
because I was giving you my short list of people that I wouldn't give the medications to. The
Yes.
last, the last contraindication for me would be people who have got severe eating disorders.
Mm.
Okay,
Yeah.
not a little bit. Not I'm not talking about a little bit of binge eating, stress, emotional eating. I'm
Yeah.
talking about serious now, bulimic disorders.
Right.
Because what we have found again with bariatric surgery, now we're finding with these medications, is that actually they could be beneficial even in this population, right? So, but in women or men, they tend to be more common with women that have got uh, these eating disorders. Then I think that we need to be careful. And what I would say, the severe ones, I would ask them to be treated first before I can even consider the use of these medications. For those that are milder, I would use a two-pronged approach. I
Yeah.
would use psychological therapies to improve that eating disorder, but I would use the medications for obesity as well, because sometimes it can be helpful even in the control of these
Yes.
aberrant eating behaviors.
Yeah. Excellent. Yeah, I totally agree. Just one final question around the use of these agents in palpitations. Ever so
Oh,
often,
yes.
I get women who come in and say, I've started this and now I have palpitations. How do you handle that?
Yeah. I mean, we know from the clinical trials that the mean rise in blood pressure is like 2 to 3 beats per minute, right?
Yes, but some
So
people feel it. Some people,
I know. Now, that's the mean. You might argue that some people can be higher than the mean in uncommon situations. So, okay, in these situations, I would say investigate the patient, do a 24-hour or longer tape to see what might be going on there. And most of the times, I must say to you, I don't find anything I, other than the sinus tachycardia or some ectopics, and then I reassure the patient. The problem usually comes from the cardiologists who are worried about patients that have got existing difficult to control fibrillation or flutter or tachycardias like that.
right,
Now, they are a little bit, which is uncommon for cardiologists, they're a little bit cautious, overcautious, I think, with the use of these medications.
mhm,
And I would say that if you treat obesity, which is one of the main reasons why these tachycardias are so resistant
distance,
sometimes, you,
yeah,
you can actually cause a benefit, right?
mm,
Again, I would think twice. I would do it slowly with slow titration and monitoring, but it would certainly not be a contraindication.
right. Okay, excellent. I think we had a fantastic discussion. And the only thing that is hindering us now is time. We are, it's not on our side anymore. But I'd like to say that we probably agree that we've had a really good session, and I'd like to take this opportunity first, to thank Lily for giving us this platform, to thank the audience for their active participation. They've put in very useful and practical questions. to thank you, Professor Miras, for all your insights on the practical aspects of using these agents and for debunking some of the myths that we have around the use of these agents. We know that obesity is a chronic and complex disease, and so far we're going to have to use multiple strategies to make sure that we overcome the complications of obesity. These injectable incretin-based therapies have really emerged as an important and extremely effective and safe agents for our patients that can be used on a long-term basis. And so we hope that we've been able to give our audience a reassurance and safety around their use for their patients. Before we end, I would like the audience to scan the QR code so that you can evaluate. It always helps when we're doing future webinars to have your thoughts around that. And with that, I'd like to thank everybody and have a really great night, and see you all soon. Thank you.